So as Ashish said, 50% of patients who are admitted to the hospital usually are malnourished, and the what makes them more prone to malnourishment is decreased oral intake, possibility of a chronic disease, cancer, and decrease in intestinal obstruction because of the whole disease which the patient is suffering from. And as Ashish already stated, that clinical effects are mostly I'll more relate to the surgical problems, that is wound adhesions, poor healing, breakdown of surgical anastomosis, and poor immune response to the patients to the infection. And more so, surgery is itself an acute stress, a stage of acute stress, and a stage of catabolic state. This is because the cytokines released during the release because of the injury during the surgery, and the release of other hormones which actually promote gluconeogenesis and increase in glucose concentration in the body, hyperglycemia, and promotion of bacterial growth, and other factors increase which lead to metabolic phase or lipolysis, and metabolic phase leads to lipolysis and ketone body production, which again affects the immune response. So for these patients in the perioperative period, we have to have a proper optimal nutrition assessment and optimal nutritional, uh, give them optimal nutrition to avoid all these issues. So what is optimal nutrition? Optimal nutrition is when you are not underfeeding the patient and neither you are overfeeding the patient, because underfeeding leads to stress induced catabolism which is not overcome, and overfeeding may lead to hypercapnia, metabolic acidosis, hyperglycemia, and all kinds of problems which can actually affect the immune response in a negative manner. So nutritional assessment has already been covered very nicely by Ashish. So I'll not be again repeating that. But one of the most important factors which actually you can do in the pre-operative period, as the discussion was going on, is the serum albumin level. This is because there was a study published in Archives of Surgery, which showed that if the serum albumin of the patient prior to surgery is more than 4.5 grams per deciliter, then the chances of mortality, 30-day mortality or perioperative mortality is less than 1%. When it goes to below 2, then the mortality suddenly rises to 30. So the optimum albumin level, which usually the surgeons also accept, is more than 3 prior to any surgery. Now, how you calculate the energy requirements in the patients who are actually malnourished, which you have assessed by your tools that the patient is malnourished. So, how do you calculate the energy requirements? So, Harris-Benedict equation is for the resting energy expenditure, and that is different for males and females. That the formula we can get anywhere. So, to that you add the stress factor. For minor surgery, the stress factor will be 1.1, and major surgery it will be 1.2. Now there will be other activity factors like the patient is confined to bed, that is 1.2. If it is he or she is out of bed, then it will be 1.3 times the resting energy expenditure. And if the patient is normal and healthy activity is going on, then it will be 1.5 times. And for fever, for every degree rise in the temperature, you add zero point 0.1 to the as a stress factor to the energy requirement. Now, a simpler method actually to gauge the amount of energy which the patients will require is around 25 to 30 kilocalories per kg per day for normal individuals, and it will be 30 to 35 in cases of moderate stress or moderate injury, and 35 to 40 kilocalories if the patient is critically ill and requires ICU management. Now coming to nitrogen balance, which is the most important part. So nitrogen balance should always be in the positive, towards the positive side, because it actually decides for the patient. If the balance is in the positive part, then the patient's recovery is better. So this is the formula which you can see on the screen, is the method to calculate the actual nitrogen loss in a day. Now, what are the criteria, which it has already been touched by Dr. Ashish, and it is from ESPN guidelines. So it is common, as Dr. Ashish told, that we think about perioperative nutritional support when there is involuntary blood weight loss in a patient prior to surgery, or the expected surgery is going to be major in terms of blood loss, that is more than 500 ml, or the patient has a body weight which is less than 20% of the ideal body weight. Then in all these cases, you have to start perioperative nutritional therapy. And Again, as I said, serum albumin less than 3 gram per deciliter or transferrin less than 200 milligram per deciliter. There was so much of discussion on all this. So serum albumin, we can get it done very easily in our setup. So as I told, based on that paper uh, published in Archives of General Surgery, that usually the surgeons want the serum albumin of a patient in the preoperative period to be more than 3 gram per deciliter if it is not an inflammatory condition. Now, uh, coming to the principle of guiding roots of what are the roots of nutrition. So, as we all know that we can provide nutrition through oral route if it is not contraindicated. If the oral route is not possible, then preferably it should be through the enteral route. If the patient is not expected to take oral diet within 7 days of surgery, and the GI, there is no GI tract contraindication. The third is the enteral nutrition. If the patient cannot tolerate enteral nutrition or there is any contraindication to that, then we can go for parental nutrition. So, what are the goals? Actually, we should at least give 20% of the calorie and protein requirement enterally, and additional can be given to through parental route if enteral nutrition cannot is not if the patient cannot tolerate enteral feeds, and maintain the parental nutrition to 75% of the calories through enteral route or oral route. Now, coming to routes of administration, when it comes to, we'll discuss one by one the various modes of feeding. So first, I'll go for the enteral nutrition. If the patient can take orally, it's fine. If it cannot, then first and foremost goal will be to help him with enteral nutrition. Now, what are the routes of administration for enteral feeding? If the patient is expected to not take orally for less than 4 weeks, then nasojejunal or a nasogastric tube should be inserted. If we expect that the patient may require enteral feed for more than 4 weeks, then ideally a surgical gastrostomy or a jejunostomy should be done. And people have compared these all these methods. Now some prefer nasojejunal feed over nasogastric feed in terms of development of pneumonia in such patients, but according to various studies there has been no difference in the rates of pneumonia whether you give feeds through nasogastric tube or a nasojejunal tube. And when should you hold the nasogastric tube? Earlier, it was thought that we should hold the nasogastric feeding once the aspirate is more than 200 ml. But now that a multi-center trial showed that if the aspirate, it should be held only when the output is more than 500 ml. And what are the advantages of enteral feeding? That you can deliver nutrients through a normal route. It stimulates enteric blood flow and increases muscle mucosal mass. It decreases the translocation of the bacteria by maintaining the barrier tight junctions and prevents development of sepsis. It induces production and release of mucosal immunoglobulins, which add to the immunity, and obviously the free fatty acids are fuel for colonocytes, which are effective way of delivering energy to the body, and it increases the gut motility as well and decreases the ileus. So the early mobilization of the patient, early discharge of the patient is possible. Now, what are the solutions which can be given through gastric feeding or the jejunal feeding? When you are considering a gastric feeding, then it can be a bolus feed or a continuous feed, and you can use both hypertonic or isotonic solution, but preferably one should use isotonic solution. When you're considering a jejunal feed, then actually the infusion should be continuous and only isotonic fluid should be used. Initially, we should start with a 25 to 30 ml per hour of feeding, and following that, we can increase it every day by 25 to 30 ml to the desired level. And usually, it is around the amount of calories depend upon the stress factor of the patient. Now, what are enteral formulas? So, low residue isotonic formulas are available with a calorie density of 1 kilocalorie per ml. So, if a patient requires 2000 kilocalories, then you should give him or her 2000 ml of the feed through a nasojejunal or a nasogastric tube. These are cheap and they are first line for stable gastrointestinal tract. Then comes elemental formula, which are pre-digested nutrients. But the problem with these are that they are very costly and difficult for our patients to actually afford this. Moreover, they are poor in fat, vitamins, and trace elements, and they have a high osmolarity, so chances of diarrhea also increases. There are few immune enhancing formulas, glutamine, arginine, and omega-3 fatty acids, which I'll be touching upon in coming slides. Now, how do you monitor when you're giving a patient feeds through enteral route? Then actually you should do electrolytes and complete blood count daily if the patient is in ICU or is requiring supports. Otherwise, for patients who are stable and who are being given enteral feeds, these electrolytes and complete blood count should be done once or twice a week. The other investigations which are important in such cases are creatinine and urea level and glucose monitoring. And obviously, you should monitor all the input, output, and body weight of the patients in such when you are giving enteral feeds to assess the adequacy of the feed. And what are the complications associated with enteral feeding? There are local problems like epistaxis, sinusitis, and nasal necrosis if you're giving a nasojejunal or nasogastric feed, and other mechanical problems like tube malpositioning and dislodgement may occur subsequently and may require a reinsertion of the tube. Then, if you give hyperosmolar fluid or a high amount of fluid or a contaminated fluid or stored fluid, then chances of diarrhea dehydration is always there. And the last and but not the least is aspiration pneumonia, which is common with nasojejunal or nasogastric feed. Then another very important aspect is the refeeding syndrome, which should always be taken care of if we have starting feed in a patient who is malnourished for a long time. And that is because of fatal shifts in the fluid and electrolytes. And what is the pathophysiology of this? It is because the patients on prolonged fasting, they have a decreased basal metabolic rate. So the body switches from using carbohydrates and to fats and to using use of fats and proteins for maintenance of energy. So in that case, the intracellular minerals actually deplete, but extracellularly the concentration remains same. As soon as you feed the patient, the glucose level rises, the insulin secretion increases, and the patient goes into anabolic phase, and the cells start imbibing all those potassium, phosphate, magnesium, and potassium, and that causes a decrease in the level of potassium and phosphate. Hypophosphatemia occurs, hypokalemia occurs in an when we start feeding acutely with high amount of calorie. And another problem is hyperglycemia, which causes osmotic diuresis, dehydration, and metabolic acidosis, because the patient who was malnourished is not very equipped to tolerate a large amount of glucose intake at that time. So, the NICE, National Institute of Health and Clinical Excellence, they have identified patients who are at high risk of refeeding syndrome, and they suggest that either the patient has one or more of the following, which includes body mass index less than 16, or weight loss less than 15% in the past 3 to 6 months, or little or no nutritional intake for more than 10 days, and low level of potassium, phosphate, or magnesium before feeding. So, in all these cases, you should always be very skeptical and very careful in starting the feeding. There are other criteria which minor criteria. If two or more of them are present, then you should always start the feeding very slowly. And how do they suggest that what should be the method of feeding is you should check for the patient who are at risk, and the feeding should be given. This slide is appearing different. I didn't expect to come out like this because I had done something, but probably I missed it. So actually, what they suggest is that you should start feeding at 0.04 megajoules per kg per day, and slowly increase it over 4 to 7 days in such patients who fit into this criteria, and rehydrate them carefully, and you should monitor the electrolytes regularly and just replenish them to avoid refeeding syndrome. And what are the contraindications to enteral feed? The contraindications include paralytic ileus, distal high output intestinal fistula, GI obstruction, diffuse peritonitis, intractable vomiting and diarrhea, shock, the patients with severe GI hemorrhage, severe short bowel syndrome, that is less than 50 to 100 centimeters of small bowel, severe GI malabsorption, and inability to access to GI tract. So, in such cases, if the patient cannot accept enteral feeds, we suggest that patients should be put on parental nutrition, which can be given either through a central route or a peripheral route. And the advantages are that the patients who cannot tolerate enteral feeds, the parental nutrition is life saving for all of them. But the disadvantages include the cost of the feed, which is always more than the enteral feeds, and long-term risk of liver dysfunction, kidney and bone disease if it is required for long duration, and nutrient deficiency, obviously. And the routes include the central line, that you place a central line into a central vein, like the jugular vein or the subclavian vein, and you can deliver formula feed through all these lines. Another method is to put a peripheral PIC line, that is a peripherally inserted central catheter, which is accessed through a peripheral vein, and it is a long catheter to which reaches the central vein. And it can it the use uh, advantages are that it avoids pricking a central access vein or a major vein, and the risk of phlebitis and the risk of thrombosis is low, and it is easier to insert, can be inserted from a peripheral route. That means it doesn't require much of an equipment like ultrasound and all. So indications of TPN, which I have already stated, are the contraindications of enteral feed actually. So if the patient is NPO for extended period, or the patient has a short bowel syndrome, severe acute pancreatitis or peritonitis, high output enterocutaneous fistula, that is in whole, the patients who cannot tolerate enteral feed should be put on parental nutrition. So what all parental nutritions are available? So first is it contains most of the parental nutritions contain first of all, it is dextrose, either 50%, or sometimes in foreign countries they even use 70% dextrose through central line. But other components include the proteins, that is amino acids can be given. They are considered as partial parental nutrition. So most common concentration in which the amino acids come is 8.5% and 15%. Then lipid emulsion is also available separately, whether it is 10% or 20% solution can be given through central route. And how do lipids actually help is that they prevent the respiratory acidosis, because the amount of carbon dioxide produced by lipid mobilization is less than that produced by carbohydrates. And it also helps to deliver essential fatty acids. And actually, it is advised that at least 10 to 20% of the calories should be given by lipids, through lipids. And obviously, there are various lipid soluble vitamins which can be given through uh, lipid drugs. The other important aspects which are to be covered while giving total parental nutrition are vitamins, and daily infusion of multivitamins is a standard technique. The others are electrolytes, which should be measured regularly and given and adjusted as per the levels. And the third is common other medications which are usually used are insulin to cover the hyperglycemia, the heparin to avoid thrombosis in the veins through which we are giving. Usually heparin flush is done, and proton pump inhibitors or ranitidine like drugs to avoid gastritis, because the patient is not being fed enterally. Now, if the central line is not available, or expert is not available to place a central line, then peripheral nutrition can also be done, can also be given through peripheral line. But the issue is that usually the drugs, the fluid which is available, or the component which is available to give the patients through peripheral route has low osmosis, and it can provide less amount of calories. Now, the TPN administration, uh, few tenets of TPN administration include that it should be started slowly as in enteral nutrition, and it is advisable that uh, infusion pump is used so a proper rate can be given, and should be usually started at the rate of 40 ml per hour for 24 hours, and then slowly increased to 80 ml per hour, which is usually the required amount in most of the patients. And of course, monitoring of various parameters like electrolytes, blood glucose, triglycerides, and ammonia should be done in these patients. Then the patients should be the lipid should be introduced slowly, because it has many adverse reactions, though it is very useful and very much required as well, but it should be given gradually. And when the TPN is to be taken off, it is gradually taken off. You should not discontinue it all over suddenly, because it may lead to hypoglycemia. Then it is advisable that if the patient is on TPN, then cyclic infusion should be given. They should be given off time usually during the day period, so that the patients can walk around, and the liver and the kidney are also less stressed during that period, to avoid fatty liver disease. Now, coming to few complications which we already know, but I'll just to enumerate them. They include hydrothorax, usually pneumothorax or hemothorax, if the catheter or the line is not placed in the right position. Then catheter-related complications include blood clot, thrombosis of the major veins, and sepsis, which may ensue because of poor handling of the central line. Then another complications are related to the feeds which we give, that include hyperglycemia or hypoglycemia. If we give insulin more than the energy required, then dehydration may occur, or fluid overload may occur. So monitoring of both the factors are very important. Urine output is a very good indicator for this. Then electrolyte imbalances can occur, acid-base imbalances can occur. Then fatty liver is a common occurrence if we give TPN for a prolonged period. And obviously bone demineralization, because the amount of nutrition which is required, micronutrients, are not provided very effectively through total parental nutrition. Then touching upon one or two slides on immunonutrition, which is a new entity which is suggested in major injuries or major surgeries. And specific nutrients which are advised in immunonutrition include arginine, omega-3 fatty acids, and glutamine nucleotides. And they are suggested to actually stimulate T lymphocytes and provide substrate for synthesis of nitric oxide, and uh, boost the immune system. And they also affect the production of inflammatory cytokines and adhesion molecules and all. There are several trials which have shown that the patients have superior outcome in terms of immune response in specifically in ICU bedded patients. And they suggest that the patients who are expected to be remain in ICU for a long time, it should be started 7 days prior to the surgery and should be given 7 days uh, post surgery. But actual benefit is not yet clear, and there are many contradictory uh, evidences which suggest that actually they do not help much. And what are usual indications which have been advised by the people who are pro immunonutrition are major neck surgery or cancer surgery, severely malnourished patients with serum albumin of less than 2.8 grams, and undergoing major oncological GI surgery, patients with trauma to more than two or more than two body systems, injury severity score more than 18, or Apache score less than 15, and with mild sepsis, and patients with ARDS. So they advise, and another aspect is antioxidant. So in patients with surgical trauma, they advise that antioxidants may mitigate SIRS, nosocomial pneumonia, and decrease mortality. So these are the all nutritional parameters which have been covered. And just to summarize, ESPN 2017 guidelines, which suggest it covers all those points which I've already enumerated. It recommends that nutritional assessment should be done prior to all major surgeries and even after surgery. Second is perioperative nutrition therapy is indicated in patients which are malnourished and who cannot maintain more than 50% of recommended intake of protein and calories for more than 7 days um, prior to post surgery. If the energy and nutrient requirements cannot be met by oral and enteral intake alone, then the patient should be considered for parental nutrition. And peri or at least post-operative administration of specific formula enriched with immunonutrients should be given in malnourished patients undergoing major cancer surgery. So, what is the clinical approach in all these patients? I will say that it starts from the OPD. Once the patient walks in the OPD, you have to assess for all the parameters which Dr. Ashish already enumerated: the weight loss, onset of disease, BMI, peripheral edema, sense of vitamin deficiency, triceps skin fold thickness, and anticipate all the post-surgical nutritional requirements. So, these can be assessed on clinical examination. Then you assess the total energy requirement, protein requirement, fat requirement based on the various parameters, the Benedict's Harris Benedict's equation, the stress factor, and the deficiency elements, deficiency which can assess by laboratory techniques, and then decide the route of nutrition in all these patients, whether you have to give enteral nutrition or whether the patient will require parental nutrition. And once you start giving all through feeding through enteral or enteral feed or parental feed, then you should start evaluating all these patients. So evaluation I've already enumerated. Most important is body weight and input output, and others include electrolytes, the nitrogen balance, and the albumin. And if the patient shows improvement over 2 weeks of nutrition, then those patients can be taken for surgery if the patients were malnourished in the preoperative period. So, concluding my talk, I would say that malnutrition significantly affects the outcome of surgery, and the identification of malnourished patients, as um, described in the previous talk, and appropriate initiation of nutritional therapy through the appropriate route helps in the patient with early recovery and early discharge. Thank you.